Hello, everyone, and welcome to the 2025 Best of Lung Cancer Science podcast from the Society of Thoracic Surgeons. We're going to explore the latest science and innovations that are shaping our field. I'm your host, Erin Gillaspie. Today, we're diving into the biggest lung cancer stories from the 2025 ASCO annual meeting and what they mean for thoracic surgeons. Joining me is Dr. Brendon Stiles, who is the Chief of Thoracic Surgery and Surgical Oncology at Montefiore Medical Center and the Professor of Cardiovascular and Thoracic Surgery at Albert Einstein College of Medicine. And he was on the ground at ASCO reviewing the latest data for us. Brendon, thank you so much for being here.
Hey, it's really great to be here, and I'm excited to talk about these studies.
There was a lot of really exciting science this year. So to kick us off, what was your overall impression of this meeting? What stood out most as a general theme for the lung cancer track?
Yeah, well, there's just so many great drugs coming, great combinations, and I think the overall theme is a continued incorporation of those regimens into earlier stage disease. And so we'll talk about the typical neoadjuvant immunotherapy, which people are probably tired about hearing about now, but it's still one of the major themes at every meeting that we go to. And how can we extend that therapy maybe even to more and more patients? We'll also talk about neoadjuvant targeted therapy, which we haven't had a chance to talk about as much. And then we'll get on some interesting topics about timing of these drugs and what time of day do you give them, and then maybe just stepping back in the big picture, what might be coming and what should we be thinking about? What drugs should surgeons know about?
I love it. I love it. Well, let's dive right in and let's unpack really what is probably the most talked about study in the last few years for us as thoracic surgeons, and that's CheckMate 816. So just to start us off, I think it's always really important to really dive back to the beginning. Can you give us a quick summary of this trial, patients included, and the study key endpoints?
Yeah, and this is a real seminal study for us, right? The first one that really reported out for neoadjuvant chemotherapy and immunotherapy. And if you remember, it was stage 1B to 3A, and these, I think, were in the 7th edition staging. It's got to go back that far when it started, who were then offered either neoadjuvant chemotherapy or neoadjuvant nivolumab plus chemotherapy. And that was given every 3 weeks for just 3 cycles. And remember, out of all the trials that we have to remember and talk about, this is really the only one big phase 3 trial that just gave the neoadjuvant component. So it didn't give the adjuvant or the perioperative or the sandwich therapy that we like. And so we really get to learn a lot about what just the effect of immunotherapy, pure and simple, early on is. And we keep getting updates and updates. And then this was finally the long-awaited overall survival update.
Yeah. And so they broke down the results into a few sort of different key areas for us. And of course, the first major presentation came out a few years ago and it was talking about surgical safety, which was critically important to all of us as surgeons, removing these new drugs before surgery. But pathologic complete response has really emerged as a huge endpoint for us in a lot of these clinical trials. Talk to me a little bit about that endpoint sort of in this context, because it really does play an important role when we start to think about overall survival as well.
Yeah, this will be the really exciting thing. And I should mention all these trials exclude patients with targeted therapy with EGFR and ALK at least, right? And so we should always remember that in our mind as we sort of stratify patients for this. But we've consistently seen that chemotherapy and immunotherapy leads to better pathologic response. And the true marker for us is complete path response. When we used to think about just immunotherapy alone, people were talking about major path response, and that's certainly important. And I think obviously can help to associate with overall survival. But what we're looking for is complete path response and strategies to increase complete path response. Uniformly, we see that number go up from sort of the low single digits to the 15, 20, 22, 24%, I think, in patients going to surgery in CheckMate 816. And then this is really going to give us the bang for the buck on what that means for overall survival. And that's what all the excitement and the hullabaloo was about at ASCO.
Yeah. So give us the scoop. What was the overall survival? Give us the breakdown for our patients.
Yeah, well, I think in the big picture, in all comers, and so the really important thing is all comer trial, and that's PD-L1 negative, PD-L1 positive, adeno, squamous, different stages. The 5-year overall survival rate was 65% in patients who got the nivolumab, compared to 55% in those receiving chemotherapy alone. And this is pretty remarkable. A lot of these patients probably came through where at recurrence they could probably get immunotherapy down the road with recurrence. And so this really, I think, speaks to the strategy of giving our best drugs up front, that leads to long-term durability of response and to this overall survival benefit. If you look across all the different subgroups, certainly patients did better and the hazard ratios were lower with the low PD-L1, but every single group seemed to show a benefit that just by getting 3 doses beforehand, you could achieve this great impact on overall survival. And I think stepping back in the big picture, just the fact that we're doing so great, 65 to two-thirds of patients, alive 5 years after with these modern regimens, I think it's a nice time for us as the lung cancer field to celebrate.
It's sort of extraordinary, right? We never talked about numbers like that historically. And so to have more than 50% of patients actually across both arms, right? So the chemotherapy arm had 55%, our chemo IO arm, 65%. Really, really a huge deal for us. Now let's get into the extra exciting piece to this. Talk to me about what really people were buzzing about, and that's the subset analysis for the patients who had pathologic complete response. How did their overall survival look at 5 years?
Yeah, pretty amazing. Those patients, 95% of those patients were alive at 5 years. I continually ask my residents in clinic and ask others around, can you guys guess what the 5 year survival will be with an overall response? And people say, 60, 70, somebody gets up to 85, but nobody hits 95%. But that is just such an amazing number. I can't emphasize enough. That's better than we do with stage one patients in the big stage one trials, right? So if we can induce a complete pathologic response, this trial really shows that we can cure those patients with just neoadjuvant therapy, right? They don't need a year of immunotherapy after. They will essentially be cured. Not a single patient died of lung cancer in that group who had complete path response. There were a few recurrences, I think two or three, but those patients were salvaged and didn't die. So that in itself is just truly remarkable.
Yeah, I agree. And I think really it speaks to this big drive that we're seeing across clinical trials to continue to drive up that pathologic complete response in all of our patients with these neoadjuvant strategies.
Yeah, it totally makes sense. And I think that should be our strategy, right? And eventually we'll get to be able to predict who's going to have the complete path response and then which groups are less likely to have. And then can we escalate there in the neoadjuvant space? Can we use ctDNA to see who we think might have had a complete path response? Not perfect, but can that be a marker? If they fail to clear their ctDNA, is that the patient who we need to escalate even in the neoadjuvant space?
I love that you've dived a little bit into this because I do think I want to circle back to one of your prior comments because I think this is really, really important. And one of the big themes that I think we've seen at a lot of the conferences this year is escalation, de-escalation of therapy, right? And trying to choose those patients in which we might be able to de-escalate therapy. And so we have a number of trials now that have come out using neoadjuvant alone or neoadjuvant as part of a perioperative strategy, with three of the major clinical trials being a perioperative strategy. So sort of guaranteeing that adjuvant phase of immunotherapy, CheckMate 77T, AGN, Keynote 671. Do you think that now calls into question whether those patients really need to be having this treatment? Should we be stopping in patients who have achieved a path CR or in patients where we've sort of decided a priori that we were going to do this sandwich or this perioperative approach? Should we be continuing or is it still too early to make those decisions?
Well, it's hard to improve on 95% overall survival. So I'm a big believer that if you have a complete path response, I tell most patients that you probably don't need the extra therapy. It was, super easy when we just had CheckMate 816 and you could say you could get 3 cycles before it. We only had adjuvant, you could get 12 after. But the option for perioperative does make it a little bit challenging. And, we've seen some, flawed analysis that suggests that maybe patients even with good responses may benefit. I think it's interesting. A lot of patients still like to get more therapy and get immunotherapy. They tolerate it pretty well. And so they like to keep going. I think it's definitely a discussion worth having. I've seen some medical oncologists say, well, if they were sort of advanced stage 3, N2 disease, and even if they have a complete path response, I want to give them that immunotherapy just to make sure. And I don't think we know the answer yet. I'm very comfortable if patients don't want immunotherapy to go with that too.
Yeah, it's nice to have the option now.
Yeah, for sure.
And without question, we're going to continue to see more of this space evolve, to your point, using circulating tumor DNA and other features as well to help really continue to make those complex decisions.
Yeah, and that was another presentation at ASCO 77T, talked a little bit about ctDNA. All the trials actually talked a little bit about ctDNA, and even in the CheckMate 816, they showed that if you clear it, you have improved overall survival. Not surprising. CheckMate 77T showed that in most of the trials, about half of patients who clear their ctDNA will have a complete path response. So it's not perfect for picking pathologic response, but it heavily trends with. And if you have a good radiographic response and you clear your ctDNA, the next thing I'll be asking, do you even need surgery? But I don't think we're there yet. But I think, you can imagine it might be going that way. It's a super strong predictor of great response. Conversely, and could you de-escalate certainly those patients who clear the ctDNA, and then could you follow them with that? Conversely, if you don't clear your ctDNA, you get some responders over time, but the complete path response rate is much less. And so is that an opportunity to escalate or to do more for those patients? The other nice thing about 77T is that they did show some data. There's in the immunotherapy space, people talk about, well, what about different mutations that aren't favorable for response? And they talk about STK11, KEAP1 mutations. 77T showed that all those patients, even with the sort of the bad mutations, still benefit from immunotherapy compared to chemotherapy and immunotherapy compared to chemotherapy alone. And I thought that was kind of an important but subtle point. Like, don't just say, oh, look, this patient doesn't have has mutations that suggest they won't respond to immunotherapy. They're still going to do better than if they just get chemotherapy. And I thought that was a great message from 77T presented at ASCO.
I agree, because that's been a huge topic of consternation is some of these co-mutations that we don't have targets for, that we're not really using in any other way right now other than to try to predict response. And I think one of the biggest challenges in all of this is we still can't predict response, right? We don't know which patients are going to have these beautiful path CRs we get to celebrate afterwards. We know the radiographic response only correlates about 1% of the time with a complete path response versus our, pathologic 24.2%. So I think a lot of work still to be done about those prediction models for our patients.
Yeah, I totally agree with you.
Any closing thoughts on CheckMate 816?
No, I mean, I just think, we got to keep looking. It's a great, great milestone to see survival like that. To me, the take-home message when I see that is, look, we've got to figure out how to induce complete path response in the neoadjuvant setting. It's just, I think, so much better than adjuvant, depending upon adjuvant therapy. I love the neoadjuvant space, and hopefully we'll keep making ground there.
Absolutely. And really sort of a wonderful, or I guess an extraordinary kind of capstone end of this really landmark study that has completely transformed how we're taking care of lung cancer patients these days.
Yeah, completely right. Pretty amazing stuff.
Yeah. Okay, now we're going to dive into the weeds just a little bit, immunotherapy. And maybe one of the most talked about presentations, and everybody is immediately going to assume that we're talking about some new drug or some new incredible predictor. But actually, we're going to talk about the time that you deliver therapy. And so there was a presentation given by Dr. Zhang and colleagues. And what they looked at was the time of the day that patients received their immunotherapy and the potential implications of this. Tell us a little bit more.
Yeah, it's pretty cool. Circadian immunobiology, right? People talk about and are throwing it around. And the basic idea is that on our circadian rhythm, you have different immune responses depending upon the time of day. And there had been a study before that I think was retrospective that suggested that there was a benefit if you got your immunotherapy before 11:30. But this was the first randomized trial that I know of, and it was done in China. And it was very busy programs, right? And they can run a lot of patients there pretty quickly. And they looked at early in the day versus late. And for them, they defined it as 3 p.m. I'm not sure that all my patients would agree that before 3 p.m. is early, but it's interesting, right? And you can kind of split the day like that.
Yeah.
And amazingly, and it was with chemotherapy and immunotherapy in advanced stage patients, same drug regimen, just given different times of the day. And their PFS benefit was 13.2 months if you got it early versus 6.5 months if you got it late in the day. And super intriguing. It backs up kind of that earlier report, and our medical oncologists talking about it all the time. It like set fire after ASCO, right? It was in ASCO Post. I think Time Magazine did something on it. All the popular press was saying, ask your doctor what time you should go in for immunotherapy. We're already getting patients starting to ask about these things, and our team here is trying to look at our data retrospectively to see if that holds up here. But it's probably something to it, right? And I think it just continues to be, immunotherapy is such an individualized response, right? There's people that we think may not respond, and people that they do. There's no one thing that does, and maybe it's as simple as time of day. But then if it's time of day and this sort of biologic thing, you can imagine it's your outside exposures. It's where you live. All these things are probably different. Because everybody's immune system's unique, right? And it's really fascinating to think about. I don't know
Yeah.
if we're ever going to be able to schedule anybody for infusions though after, at least the other one was 11:30, so you can still work with the second half of the day.
At least 3 p.m. gives us a little wiggle room. But, when we see a hazard ratio of 0.43 in any study, we are just over the moon excited. And here we're seeing, a PFS difference, like doubling of PFS, hazard ratios of 0.43. And really it bearing out in a prospective manner. They saw it across multiple cancer subtypes. It was just, as you mentioned, this repeated signal that everybody's seeing in these retrospective studies. So they said, we got to look at it. We can't just keep ignoring this. And so they put together this beautiful trial. And I do think that it's something that we need to be thinking about, the future of this diurnal immune response and how we leverage that to really get the best possible outcomes for our patients.
Yeah, it's such a cool thing. I think we'll see more and more studies about trying to induce immune responses with non-pharmacologic methods, right? And I think that will be a pretty interesting area to explore. And I think patients will sort of like that and sign up for studies like that for sure.
Yeah, I think so too. I think so too. So more to come, hopefully, with that for all of us. Let's jump back into our neoadjuvant space.
Okay.
So one of the eagerly anticipated studies, of course, was NeoAdora. I think, the Adora trial really swept the world by storm, right? It led to a very rapid incorporation of us talking about mutational testing in all of our early stage patients, making sure that anybody who qualifies, so appropriate stage LA5-8R mutations, exon 19 deletions, can be considered for adjuvant osimertinib with, really these hazard ratios like we sort of saw, and we're just talking about from this other study that was presented at ASCO. And osimertinib became this really important tool in our armamentarium for the treatment of early stage lung cancer. And so really unsurprisingly, much like many of our drugs, we're moving those into the neoadjuvant space. And so we have the NeoAdora trial. So talk to us just a little bit about the NeoAdora trial, how it was structured, our 3 different arms. How did they move osimertinib into the neoadjuvant space?
Yeah, another great trial that we've been waiting a long time for and super excited about as well. And it really asks the question of, we know from Adura that patients with EGFR mutations, common EGFR mutations, get a great benefit from the drug after surgery. Do we see a benefit preceding surgery? And we also know that studies have come out over time talking about FLAURA2 and talking about the benefit of chemotherapy versus osimertinib alone. And now we know that there's an overall survival benefit there. So does it make sense, if we think that you've traditionally gotten some benefit from chemotherapy, what do we think about osimertinib alone versus OC plus chemo? And so this was a trial that really looked at that. It looked at chemo only. So it took patients with stage 2 or 3 clinical lung cancer with EGFR mutations, exon 19 deletion or L858R, and it gave those patients neoadjuvant therapy. They were randomized 1:1:1. It was an international trial all across the world. You can imagine a lot of patients were from Asia, as is common with EGFR trials. And patients either got oral osimertinib once daily, and remember this is a pill for all the surgeons out there, oral osimertinib plus chemotherapy, or chemotherapy only. And this was typically pemetrexed carbo or cisplatin. And then they compared outcomes, and like most neoadjuvant trials, compared MPR and PCR, and then got an early look at PFS.
Okay, so MPR. This was actually the main endpoint pathologically that they were looking at. And I think this surprised some people. So talk just a little bit about really the theory behind sort of targeted agents, thinking more about MPR
Yeah.
versus our immunotherapy and using that PCR.
Yeah, it's pretty interesting, right? I think that most people who have been in the field for a long time think that these drugs, they certainly see some cytotoxic effects early, but think that they're static. And almost everybody who's on targeted therapy, particularly GFR targeted therapy, will develop resistance and recur, sadly, is the current state of affairs. And so I don't think people expected a huge PCR, which is why it wasn't really put as the primary, but I think we thought we'd see some. I think certainly most people thought that we'd see a big benefit from adding chemotherapy to osimertinib in terms of major path response and in terms of complete path response. But the interesting thing, like you alluded to, is that they were essentially identical. If you got OC plus chemotherapy, the MPR rate was 26%. If you got OC monotherapy, it was 25%. And chemo is only about 2%. And so it didn't really change things there. Interestingly, with PCR, it was actually higher with the OC alone, and I forget exactly what it was because it wasn't a focus, but I think it was like 4% versus 9%. And maybe that's just a statistical aberration. But for me, it reinforces the idea that these drugs themselves don't completely get rid of disease, right? And that really highlights the importance of good local therapy and good surgery in that setting to me.
Yeah, absolutely. And so we have, about 350 patients enrolled. They get these different drug treatments. And then one of the things that I thought was super exciting, because it's something that is a big point of consternation for surgeons with a lot of these neoadjuvant trials, is the drop-off rate that we see in patients going from this neoadjuvant regimen into surgery. And we see that more than 90% of the patients in this trial are making it to surgery. So are we getting better at delivering neoadjuvant treatments? Are we getting better at our handoffs? Is this just better tolerated?
But I
Talk to
think
me about this space.
Yeah, no, I think that that's one of the key take homes, right? Is that we can get patients safely to surgery. And these are pretty heavy burden disease patients. I think over a third had N2 disease and half had stage 3 disease. Number one, they're probably a little bit healthier and less sick than some of the patients in the immunotherapy trials, right? So they don't drop off for medical side effects. Osimertinib, I think, is one of the best tolerated drugs in the world. It's easy for me to say, harder for patients to say, but it really is just an amazing drug in terms of side effect profile. Um, and it's great. It's got over 80% response rate, right? And whereas immunotherapy, some patients, they're just cold, they won't respond. Almost everybody responds, at least initially, to EGFR TKIs. So almost everybody gets to surgery, and really safe surgery, I think, is a really important part. No real extra side effects with getting the drug up front. And so for me, and we'll talk about a little bit then, where do we find this like in our space, in our armamentarium? How do we think about giving neoadjuvant versus giving adjuvant? If it's not a huge bang for the buck, which patients should we give this therapy in?
Yeah, absolutely. Absolutely. So, we're seeing PCRs, little bit of a surprise for a lot of people because, again, to your point,
Yeah.
static versus a lytic drug. We're actually having good MPRs, right? We sort of expected that. We're definitely trending with EFS survival benefit for our chemo OC and OC alone arms compared to our conventional chemo placebo arm. So what do we do? What do we do?
Yeah.
Because really, to your point, and this is a really important one, we know that these patients at some point are likely to stop responding to this drug, right? It's not everybody, but over time, we're selecting for different mutants. Cancer smart, it figures out a way to sort of survive in this setting of static disease. And so local control, super, super critical. But do you think we're going to see an overall survival benefit in the Neoadora that's different from the Adora, or is it just the delivery of osimertinib in this patient population that is going to be critical, regardless of whether it's before or after?
Well, this is how I think we should think about the space. And I think, a lot of surgeons will still probably say, oh, well, look, it's the same. You're going to get a benefit if you give it adjuvant, and they'll use that as a reason to operate upfront. And I think that's probably okay. I think stage 3 patients, though, given our best systemic therapy first, will hopefully get people to the operating room safely and help, with 90%. And so I think that's best for the patients, if they have stage 3 disease. We know from the LAURA study that those patients who got chemoradiation, in the control arm, boom, they went straight down. So it's the almost equivalent of systemic disease.
Yep.
I think smart surgeons should use this to expand the patients with N2, maybe even N3 disease, big bulky tumors that they might operate on, right? Because great response, right? And we see downstaging clearly with this, even if they didn't have a complete path response. And I really believe giving that first, rather than a prolonged period of chemoradiation, then followed by, or even surgery, getting patients back from surgery over postoperative complications, potentially after a big operation. I love the idea of the marginal patients, the N2 patients, the patients with bulky tumors, trying to give this first and maybe changing the operations that we do, doing a safer operation, a minimally invasive operation. I like, and I famously have a patient that I remember who's dear to me, who came in really needing maybe a pneumonectomy, maybe a sleeve on the left side, and we gave her OC neoadjuvant, just everything shrunk when we did a Vaxlovid, and she was home right away and did great. And I love that strategy for patients with bulky sort of advanced disease, and I think we'll increasingly start to use that more, I hope.
Yeah, absolutely. It's that kind of continuing conversation all the way of that borderline resectable, especially, right? Can we actually truly turn more and more of those patients into resectable? And now there is actually neoadjuvant trials trying to turn truly unresectable patients into resection candidates. And so potentially using these strategies is a big way to increase surgery as an effective local control for patients.
Yeah, and I'll make one point on that. And
Yeah.
stage four too, right? We always talk about oligo
Yeah.
disease, but I think the
Yes.
take home from Neodura to me is that, right, the drugs alone aren't killing all the tumors, right? There's viable tumor after prolonged periods of getting these drugs, even with chemotherapy. That has obvious implications for the stage 4 space, where we see great responses, right? So then we're going to need to have some local control there, right? And the primary tumor in particular, which we think of as sort of the main spot of drug tolerant persister cells and seeding of metastasis. We should think about surgery more in that setting, right? Because all the reasons that you get drug tolerant persister cells also lead to radioresistance. I think the default has been historically to just irradiate those tumors after systemic therapy, sort of in the oligo state. I think there's a real role for surgery there, though. I think we can clear disease, get all those persistent tumor cells out, and I think the eye-opening thing to me with Neoadura is that how much persistent disease there is. And I think that translates to the stage 4 space too.
Yeah, unquestionably important for local disease control. And in addition, surgery provides sort of this unique added benefit of allowing us to have a huge amount of pathologic information, right? Tissue is always the issue.
Totally.
Stewardship is critical. It's going to continue to help inform treatment decisions once you progress through that first line. And if you have a single site progressor, maybe with some resistant cells there, it might not be systemic, right? And so you might be able to still continue that treatment and just identify key areas for local control.
Yeah, absolutely.
Very, very exciting. So let's dive into one last topic before we wrap up. Datopotamab deruxtecan is getting a lot of press across a lot of different treatment strategies. So we've heard about NeoCOAST 2 in the last year, using this drug in the neoadjuvant setting, again, working to try to drive up that pathologic complete response. I think there was a collective gasp in the auditorium last year at World Lung when I think it was Tina Cascone said, hey, we're seeing preliminarily a 34.1% complete pathologic response using this drug. We have Tropion-12 looking at using this in the adjuvant space for early stage lung cancers. And then, of course, Tropion-Lung02, which is using it in the more advanced space. So talk to me about Dato-DXd. That's what everyone calls it for short. What is this? Why are we hearing so much about it? How is it going to continue to shape treatment regimens going forward?
Yeah, it's interesting. So they presented Tropion-Lung02, and like you say, we're sort of getting overwhelmed, not only with studies on Dato-DXd, from which we've seen just study after study in the EGFR space, the non-EGFR space, but all these ADCs, right? And these are antibody drug conjugates, and surgeons are going to have to know about these. Basically, people talk about it as smart chemotherapy, right? Or Trojan horses, where you take an antibody, you link the chemotherapy to an antibody, and try to target cells specifically that express that. It's thought, that, a couple take homes, right, in the big picture. In theory, that should reduce toxicity, right, because you're targeting your chemotherapy directly to the cells expressing your sort of your antigen of choice. But it hasn't. They have like unique sort of safety issues, right, and some things with these drugs I think that we have to be aware of. That challenges the adoption in the neoadjuvant space a little bit, where it's hard to tolerate. But I do think Dato-DXd is important for us because it's coming, and Tropion-12 is an adjuvant therapy sponsored by TSOG and sponsored by TEST, the European platform, about giving this drug with another drug called rilvegostomig in the adjuvant setting. That's a lot of drugs for stage 1 patients, right? It's stage 1 high-risk patients. But I think it's interesting, right? And we know that these high-risk patients have recurrence rates of 30% in CLGB, up to 40% with high-risk features probably. So I think it's very reasonable. But the exciting thing here was they compared this drug and Tropion-Lung02 presented at ASCO with that drug, this ADC, plus Pembro versus standard chemotherapy plus Pembro, right? And so it's specialized chemo with Pembro versus traditional chemo with Pembro. And safety signals are about the same, response rates were about the same, all that stuff looked pretty good, right? No surprises there. And so it held up with the single agent thing. And somewhat intriguingly, though, they had improved response. And so, again, small study, I think it was less than 80 patients, but median PFS was 11.2 months in the doublet therapy versus 6.8 months with the triplet therapy. So it got people kind of buzzing and talking about, maybe these drugs, might work better. And then, like you mentioned with COAST, right? If you add that in there with neoadjuvant therapy, can you increase your PCR? I think the challenge for us as surgeons in the neoadjuvant space is going to be getting patients through the cycles and making sure that they don't have toxicity from it. The challenge in the adjuvant space is going to be pretty unique, right? These are stage 1 patients who generally think that they're cured, and getting them to stay on drugs that are a little tough could be challenging. And so they get stomatitis, it's one of the bad ones that happens. There was some rates of pneumonitis, which we have to watch out for in the neoadjuvant space, about 20%, but generally pretty mild. So keeping an eye on those things, and I think being familiar with the space. We're going to get flooded with ADCs, right? And bispecific antibodies, all these other things. And so I think it's good for surgeons to have at least some cursory knowledge of what's happening out there.
Absolutely, absolutely. Continues to make our handoffs, communication, getting patients through every single phase of this pathway more and more critical. But I think also emphasizes some of the importance of collaborating with so many partners, right? It's not just us anymore. It's our radiation colleagues, it's our medical oncology colleagues, but it's also our pulmonologists who are doing a lot of the biopsies up front, and we're needing their help in getting enough tissue to figure out, do we have a molecular target? Way more molecular targets coming into that neoadjuvant space, right now with so many clinical trials ongoing, drugs coming into that adjuvant space as well. And then, of course, our pathologists who are now being tasked with giving us a lot of information to try to help make treatment decisions. So, residual viable tumor, there's a lot of standardization work going on with how do we report the treatment effects as we really start to bring all of these clinical trials out of trial phase into application phase across the country and across the
Yeah,
world.
definitely no fun for the pathologist, right? These are hard, these big tumors to score and to sort of figure out, I think, is a big challenge. But we will increasingly rely on them as treatment decisions are made upon path response, no path response. I think for us, we have to figure out how to predict these things a little bit better. I think surgeons should definitely be in that space. I think the idea of high risk stage 1 for adjuvant therapy, that's surgeons talking to patients, right? And because most of these patients aren't going to see medical oncologists, they trust their surgeon. And so I think understanding a little bit the drugs and the space, the benefit, but the potential side effects will be important for us at the point of care.
Absolutely. And when to refer, right? When to
Yeah,
really tap your
100%,
colleague and say, hey, I got to get this patient in with you. I'm worried about some of these high risk features.
for sure.
Fabulous. Well, incredible summary of really what was such an exciting meeting for lung cancer, I feel like. And obviously, highly biased thoracic surgeon, love of lung cancer. But man, I will tell you, every meeting I go to, it feels like lung is the hot topics, great presentations, incredible trials reading out. I mean, this is what an incredible time to be in this field.
Yeah, I mean, it's incredible if you think about it, right? That was back in June, and I think we've already had World Lung and ESMO, and each of those trials, we've seen updates, we've seen new subgroups, we've seen all this other stuff, we've seen more data on Dato-DXd and all these other new drugs. It's moved so fast just since ASCO, and that's like a good problem to have.
It is. It's a great problem to have. All right. So, in wrap up, we've talked about a few themes throughout. What are some of the major themes that you've seen really in the last year woven throughout meetings that you think are going to continue to keep popping up for us over time?
Yeah, well, I think maximizing pathologic response in the neoadjuvant setting. I think the pendulum has clearly swung to the neoadjuvant space, and so we need to keep up with it. I think keeping in mind with that biomarker testing, we just have to keep hammering that home. Good stage and good biomarker testing for every single patient should be standard, just like a CT scan. I think that we're going to keep getting as surgeons into more advanced disease, right? Making unresectable resectable, so-called unresectable resectable. And I think, as you'll sort of cover big topics at ESMO, big topics at World Lung about that. And I think surgeons should be in that space, right? I think that these drugs allow us to treat some patients that we might not have been able to treat before. I fundamentally, as a surgeon, believe that local control is better with surgery than with radiation therapy. And so I think that if I was a patient, I would want that shot of getting my best systemic therapy first and then getting my best local therapy. Obviously depends upon a lot of things, but I think I'm excited about that space. And then new drugs, right? And figuring out how to match these drugs with the right biomarker driven approach, I think will be key. But I also think, and I'm running on and on here, I realize that we
No, I
might
love
get
it.
to the point of de-escalation, right? And that's, if we could do that for our patients, whether it's not operating, not doing somebody that starts with a pneumonectomy and you're pretty certain they had a complete path response. How bad do you feel when you do a pneumonectomy there, right? Or even if you take out some tumors, are there patients we could de-escalate the surgery on? But then certainly are there patients we could de-escalate the systemic therapy on, right? And I love it. Medical oncologists always talk about de-escalating the surgery, but they're not as keen on de-escalating the systemic therapy. But I'm kind of the other way around, and I think we can find the right times to de-escalate systemic therapy, which will have huge cost-saving advantages.
Absolutely. And de-escalation of therapy, one of the advantages that I always think of is we have a certain number of cards, right, that we have to play against lung
Totally.
cancer. We want to make sure that we're fighting it as effectively as possible. And gosh, if we get to keep something in our back pocket to play at a later time, whether that is a local therapy, like, what we can afford, a lobectomy, pneumonectomy, whatever it is, or another drug, I mean, that's always such an advantage that we have down the line for a patient who recurs. And so I think de-escalation is going to be super important as we head into this future, as is escalation for the patients who aren't having the response that we hope that they've had.
Yeah, I totally agree. And another theme that you hit on with liquid biopsies, I think we'll get better and better at when can we de-escalate and when do we need to re-escalate it even before radiographic changes. So I think it's super exciting times.
Absolutely. Absolutely. Give us your couple key takeaways from the discussion today, from these trials for our listeners to ruminate over as they think about this podcast.
Yeah, just early biomarker-driven therapy, getting our best systemic therapy in first, I think, is key for patients. I think quality surgery to identify those patients who still had residual disease and might need more will always have a place. And so surgeons should be in the space and keep doing what we're doing. We're doing a great job with these.
I love it. I love it. Dr. Stiles, thank you so much for joining us and helping to translate these findings into surgical insights. For
Totally
all
a pleasure. Totally a pleasure. Thanks for the expert moderation as always.
Thank you. Thank you. For all of our amazing listeners, you can find out more information and related resources at sts.org and in the show notes. Until next time, I'm Dr. Erin Gillaspie, podcast host at the Society of Thoracic Surgeons. Please be sure to follow the 2025 Best of Lung Cancer Science podcast special edition series, which is now available on all of your favorite listening platforms, including Apple, Spotify, and iHeart. And don't forget to follow me on Thinking Thoracic, an STS podcast that offers candid conversations about the latest advancements and challenges in thoracic surgery. Until next time, keep smiling.